Well, thank you, Naima, and thanks so much for not showing that picture. I know if Joe Marks really had control over the technology, it'd be up there right now. I can just tell you that back then I could let my hair down. So times have changed. Anyway, something to look at another day. It's really great to be here with all of you. As Naima said, this is my first PHSSR Keeneland conference, but I certainly have been an admirer of the work that all of you have been doing over the years. And I think that as a practitioner in public health, the work of researchers is so vitally important. So it really is a real honor to be here and share my thoughts with you today about reimagining public health. Now, what I'd like to do with you this afternoon is go through a few things, really want to talk about some of the changes that are going on in our larger environment in terms of public health, and then I hope provoke some thinking and some conversation, and I hope some creative thinking and imagining and reimagining about exactly what is our business in public health and where do we need to go. So what I'd like to do is really acknowledge that here, the second decade already of the 21st century, I think there's at least 5 major things in our environment that are really affecting public health. And I'd like to explore these things with you this afternoon. So one is really the fact that we're losing ground in life expectancy in our country here in the 21st century. I think climate change is another area that we need to talk about. The slow economic recovery, again, having tremendous impact on public health. The whole growing phenomena of distrust in government has implications for us. And then health reform, of course, in terms of the ACA. So let me start with health reform. And what I'd like to do is, of course, it's a huge topic. I could just talk about that this afternoon, but I won't. I'm just going to give kind of a little executive summary, but maybe not as brief as the vice president's was. I'd like to talk a little bit more than he did. And what I'd like to do is really focus in on the conversation around prevention and public health. And just on this screen, I think there's some key things that are coming through health reform that really have tremendous implications for public health. So I think we have the opportunity, based on health reform, to move out of clinical services, or for those health departments that can't, that we can really enhance revenue sources and improve clinical services. I think we have the opportunity to connect community-based prevention with clinical prevention. I think we have new opportunities to partner with clinical care providers to improve care, for example, around decreasing readmissions. I think based on the National Prevention Council and the National Prevention Strategy, we have something concrete that we can really model efforts to do cross-sectoral partnerships on local and state levels as well. I think with the community transformation grants, we have an infusion of new funds that really go to the opportunities around enhancing community prevention and, again, making multiple partnerships possible. And then finally, I think we have, with the new IRS requirements related to community benefit and hospitals, that we have tremendous opportunities for engaging, again, with healthcare providers and with other providers in the community. But I think what's interesting is that, there clearly is a lot of conversation about healthcare cost, and healthcare reform. But I think in the background, at the same time, we're starting to see that the community is also talking more about prevention. So this slide and the next couple of slides are from some polling and focus group research that the Foundation and Trust for America's Health had done this fall. And it was done by Greenberg, Quinlan, Rosner Research. And what I'd like to do is just kind of focus on how this conversation about prevention is starting to change. And I think it's because of some of the things changing in the environment around health care. So in our focus groups, which were designed to really cover the entire political spectrum and did have some geographic diversity as well, we found that nearly all of the participants agreed with the statement that you see up on the screen, that, quote, getting good doctor's care is important, but we all know it takes more than just seeing a doctor to stay healthy. And then the statement goes on to talk about how prevention really has to take place outside of the doctor's office. And it's something that people are increasingly resonating with. What we've seen in the polling data that was part of this was that people perceive the value of access to safe places to exercise and getting healthy food as equal to the value of clinical care. And what we've seen again, this is comparing two polling periods, right? So what we've seen is that there's a slight increase in the perception of the public that where we live does matter to our health. Although I have to look over at those two black columns there, over a third of our respondents really didn't see that there was a connection between their community and their own health. So very interesting, and I think that has implications for us as well. I think we've seen some consistency here across the two time periods, that there's a continued call for investment in prevention. And what happened with this latest poll is that actually the folks that supported increasing prevention now support it with even greater perhaps urgency or strong belief that it really needs to happen. And that lastly, in terms of just sharing a few things from this recent research, that as people talked with us about what is the value of prevention, it really centered in on saying there's two things that are really terrifically important. And one is the future of our children, and the other that really resonates for people is the economic value of prevention. So again, important pieces of what is changing, I think, in our environment as we have this national conversation and this national experience around health and healthcare reform. Let's move to the second area, which is really around distrust of government. And I think we all would agree that Congress probably is the poster child for distrust, and explained here with this cartoon of receiving the worst supporting actor. But behind this is the Pew has been doing, the Pew Research Center for People in the Press, of course, have been doing these polls around trust in government over the past 55 years. And in the fall of 2012, we, of course, reached the lowest point of trust in government. The question in this poll is, how much of the time do you trust the government in Washington? And trust equals just about always or most of the time. So you can see that that has fallen off tremendously. Now, the good news, I guess we could say, for public health, at least for those of us that have worked at the state and local level, is that distrust is not as great in the state and local government. In fact, there's still majorities at the state level that trust government, and at the local government, it's actually 2-to-1. But I think it would be important to look, and you can go to the Pew Center data online and look behind some of these apparent trends and really look at the details here, because I think even though It's promising. There are some warning signs. First of all, we do see the trend is going down over this period. And we also see that people have real concerns about their state governments in terms of the way that they're using folks' tax dollars and the belief that there's too much partisan rancor and disagreement, and things are not getting done. And I know for those of us that have worked in local government, it varies, but those themes certainly get pulled up in political conversations and have a lot to do with resources and how resources are used. The third area that I'd like to just touch on with you this afternoon is the slow economic recovery. And you can see here, the good news is we're coming out of the recession, and the bad news is that we're coming out of the recession. I think for all of us, very much aware of the fact that the driver here is the recovery of employment, of jobs, and that that's been much slower than what everyone has been hoping for, although the trend is still going in the right direction. This chart is from a report from one of the regional Federal Reserve offices that really looked at state and local governmental spending. And I think what's interesting here, so the red line is the current recession, and what's happened, and the 0 point is when the recession was officially over. And so what we're looking at is, in the gray area, kind of the range of the last 8 recessions in local and state spending. And you can see the average line there in terms of black. And you can see that our current trend is very, very different in terms of state and local spending. A lot of that has to do with the housing crash in terms of really decreasing revenue to local government. But it also has to do with, of course, the current economic climate and the political climate really looking at concerns around the deficit, and we're certainly seeing that with the sequester, and the impact on budgets. And in this case, this is not even factored into this graph. So what about climate change? I think we would all agree with these young people that we didn't ask for climate change, but in public health, I think it's something that we perhaps intellectually recognize, that there's tremendous impact on the populations that we serve. We can see in this great slide from the Public Health Association of South Africa, what are the exposures, what kind of things are modulating those exposures, influencing human health, and then what are the health effects? And we can see there's a wide range of human health effects, ranging from increased temperature-related illnesses and death to increases in vector-borne diseases, foodborne and waterborne diseases, et cetera. What we know is that right now, CDC does have a relatively small program around climate change and public health. Only about 16 states have funds that are working on climate change and public health. But every state receives public health preparedness funds. And this is from TIFA's report last year, which again showed overall that we've made tremendous gains in the past decade. But in this area specifically of climate change, and it was part of the scoring this year, only 15 states at that point of the survey had climate adaptation plans as part of their comprehensive emergency planning and response guide. So this is something that I think is really, again, an important issue for all of us in public health and a major factor in terms of our larger environment. Last but not least is really looking at what's happening with our country in terms of losing ground around life expectancy. This slide is probably familiar to most of you, just kind of showing the difference between the US and its peer countries. And what we know is that there's a tremendous set of intersecting dynamics in our population that cause us to have shorter, sicker lives when we look at our peer countries. Everything from tremendously higher rates of uninsurance to tremendously more inequality in terms of income, the weaker safety net that we have in this country in terms of social services, sedentary lifestyles, obesity, higher rates of drug abuse, higher rates of alcohol and vehicle crashes, and greater use of firearms and in acts of violence. So I think many of these things are interacting, and as we saw in this report that was issued at the end of last year, in terms of looking at the international perspective and differences in life expectancy, that in shorter lives and poorer health, the IOM's report at the end of the year, what we really see is that our younger people in this country across the board have shorter life expectancies than those in our peer countries across the world. And Dr. Steve Wolf, who was the chair of this panel, said that the panel was struck by the gravity of these findings. I think we can also kind of look at this in a number of different ways and see that we've been losing ground here over time. So if you think about the great, tremendous gains we made in life expectancy in the 20th century and contrast that with what's going on now, it's quite disturbing. This gets put in even starker contrast when we factor in the tremendous geographic, socioeconomic, and racial disparities in our country. In this article by Murray and Izzati, what they did was really look at and compared life expectancy by county, okay, in aggregate over 10 years, and compared that with the what they called the frontier countries, the countries that were leading the way in terms of life expectancy. And what we see with the orange and red counties are the counties that in our country are up to 50 years behind those frontier countries in the world. Notably, in their article, they point out that between 2000 and 2007, 85% of counties in the United States fell further behind in life expectancy, again, when compared to our peer countries, the leading countries in the world. So finally, we just have to think about how all of these factors, and there are more that we could probably talk about this afternoon, how they interact and how they're really shaping the environment for public health in the 21st century. So we have to think about what is it that we as public health are bringing to the table in terms of addressing these changes. And I think I want to give credit to Dr. Eduardo Sanchez for this concept. But what Eduardo has said is that our predominant paradigm has been one of sinks and toilets. That in the 20th century, that you could really say this is kind of our metaphor for public health. And it's not to belittle public health at all, because when we think about the conditions, particularly at the beginning of the 20th century, and how public health was constructed as part of a larger social movement that addressed housing and sanitary conditions, poverty, the working conditions in factories and sweatshops, the fact that drugs and food were completely unregulated, that what we came up with, or what our grandparents and great-grandparents came up with in terms of a public health model, was very appropriately addressing infectious disease. And really, what we can reflect on is that public health was tremendously successful. When we think about and look back, we can see that they did everything we are trying to do, igniting a social movement that really addressed policy, law, that addressed changes in and created new ways, new structures, both nonprofit and in the community, and in government. So what we had was a very successful start and building of public health infrastructure in the early 20th century that very effectively targeted what the problems were. And what has happened over that time is that public health became kind of indisputably in charge of the sinks and toilets part of this whole thing. Nobody's competing with public health in that space, right? We are doing it. We are leading the way in terms of sanitation. But the problem is that our problem is changing. And it's not that we have to forget about and say, hey, we're not going to do that stuff anymore. But now we have the challenge of doing more. And I think my experience has been that we continue to come to the table talking about the challenges with the predominant mindset of, but this is what we do, and this is what we do well. And hey, you guys aren't recognizing us for what we do. So I think what we need to do really is have some serious discussions, and I know we're doing this across the country, around reimagining public health. And I guess I would ask you, what is your metaphor? Is it that we have to exert some force and tear down what we have? Is it that we keep the dog but get rid of the spots? What exactly is your metaphor? And I guess we need to come up with a new paradigm, but at the moment, as this woman says, this mostly involves replacing moving forward with new paradigm. So we really haven't come up with this language yet. So I'd like to just put a concept out there that actually, again, I'm borrowing from Trust for America's Health, that basically helps us think about anticipating what's going to happen next, because that was the greatness of Wayne Gretzky. He could anticipate where the puck was going to be and skate there and not just chase after the puck. So likewise, we need to anticipate where are things going and position ourselves as public health to be there. And this concept of chief health strategist has been put forward by Trust for America's Health, and I find it very intriguing because I think what it means is that it charges us with doing things in a new way, and it charges us with being very thoughtful about bringing partners together, earning a leadership role in what we do, and really looking at identifying what are the particular conditions, pulling the data together, analyzing the data, and being able to work together to facilitate partnerships not only in health and healthcare, but across the community that really focus on improving health. Now, I think in order to do this, we don't need good health departments. I think what we need are great health departments. And I think what has happened is that too often we're satisfied with being good. And we really need to push ourselves harder and say that we need to be great. So Jim Collins, in his work on From Good to Great, identified these kind of three key things that really form or kind of lead to a process of a great organization: superior performance, distinctive impact, and lasting endurance. And Collins talked about how this is really made up. You know, organizations don't just show up being great. It's really a process that involves discipline in terms of people, disciplined thought, and disciplined action, and then really finding a way to build that into a sustainable economic model or resource model. At the core of this, and I guess I would challenge all of you to tell me where PHSSR is making a contribution, is the core of this is this notion of what is unique about this field that's an intersection between our passion, which has to do with our mission and our values, what are we unique and best at, and how do we pull together resources to make this a sustainable model. That's what we have to discover for public health. And I really would like to invite us to have some conversation both this afternoon and as the conference goes on and in the social media space about what exactly is PHSSR contributing to making and helping health, public health, move from good organizations to great. I know that we've had over 80 finished as well as ongoing PHSSR studies, many of which, the vast majority of which actually fall into the area of structure and organization. A good number are focused on finance, and a good number define and describe practice. But again, most of our studies are describing what it is that we're doing. And I think what we have seen, particularly as we talk to policymakers, is that they want to understand not only the description, but what does that have to do with outcome? What does it have to do with impact? So again, my thesis is that I think we have to find ways to bring the relevance and the importance of the work that you're doing to practice, to inform how we create great health departments that have superior performance, distinctive impact in their community, and lasting endurance. Because I think we've all been involved in these conversations about transforming public health. And that's great, and we need to have more of them. But we also need to remember that our field really has so much to do with not only gathering data, analyzing it, having the conversation, understanding it, but what was that critical thing that John Snow did and that all public health people do is actually taking action, taking the handle off the pump. So we need to move forward and reimagine public health. And I really look forward to the conversation this afternoon and on through the conference as we explore these themes. Thank you very much.